Hello, it's Erin, your friendly ER educator, and we are going to talk about vasopressors. So just the basics. We're not going to get super in depth with this, but we're going to look at common vasopressor medications. We're going to look at titration and then nursing considerations for when you're caring for your patient who's on a vasopressor. All right, so objectives of the course, we're going to look at indications for vasopressors. We're going to look at common ones. We're going to talk about equipment needed to run a vasoactive drip. We'll talk about a little bit of titration. We'll talk about nursing considerations for a patient who's on a vasoactive drip. And then we'll practice titrating a vasopressor by reviewing a case study at the end of the presentation. All right, so let's briefly talk about how a vasopressor medication is going to work. So vasopressors typically are going to constrict blood vessels to increase blood pressure, help with cardiac output, and help vital organs get the oxygen that they need. Typically, they're used to treat shock and hypotension. They have a variety of mechanisms of actions, and we're going to look at different vasopressor meds and look at how they work on different receptors. And they each primarily do the same thing. However, some of them have a little bit different mechanism of action. But in general, vasopressors are going to increase cardiac contractility. Not all of them, but most of them. We're going to increase systemic vascular resistance. With that increased systemic vascular resistance, that's going to help us raise our mean arterial pressure. And we know that when we raise our mean arterial pressure, our end organs are going to have that feeling of oxygen and get that good perfusion out to them. So in general, they all kind of work the same way. They work in different areas. So when we look at the different meds, we'll look and see how they might be just slightly different. When we think about patients that would need a vasopressor, typically it's going to be your shock patients, right? We see this often in sepsis or cardiogenic shock or hypovolemic shock. Certainly patients with heart failure, those have had a heart attack, again, sepsis, pulmonary embolism, pulmonary hypertension, some cardiomyopathy patients. When we look at contraindications, there aren't a lot. And part of that is because some of these vasoactive medications are actually catecholamines, which our body produces naturally anyways. So unless there is a documented hypersensitivity reaction to these things, there aren't a ton of contraindications. However, you need to be careful in patients that have uncontrolled dysrhythmias and then certain recent cardiac events. So like if the patient just had an MI, or they are in acute decompensated heart failure, you need to kind of look at risks and benefits and decide if it's safe for them to be on a vasoactive medication. So all things to consider, the doc needs to make a really good educated decision based on the patient's presentation and comorbidities to determine if this is safe for them to use. All right, so let's look at some common vasopressors, and we're going to go a little bit more into these in just a little bit, and I'll break them down a little bit more. But it's kind of broken up into kind of three different things. First is your catecholamines. Your most common catecholamines would be like phenylephrine, norepinephrine, epi, and our body naturally makes norepinephrine and epi. So we have some of these just kind of floating around. That's how we get that fight or flight response during times of stress. But we have these medications that are kind of like this synthetic version that we can give to help with this if the patient needs it. They're in shock. Others, we commonly will see things like dobutamine or dopamine. It's not super common in our practice. Most of the time we're going to see epi or norepi, but they certainly could be an option. So breaking them down a little farther, we'll look at kind of phenylephrine, norepi, epi, and then dopamine, like a little bit more in depth, and we'll look at vasopressin also. But phenylephrine is interesting. It's a pure alpha-1 agonist, so this is going to induce peripheral artery vasoconstriction. It's going to help with our blood pressure, our MAP, and our SVR are going to increase. Norepi, which is a very common vasopressor, we use this for a lot of patients, and I'm going to talk about why some of these are better options than others, especially if you have to think about titration. So we'll touch on that in a little bit. But norepi, the other name for that is Levophed, has mixed alpha-1 and beta activity. So this leads to a more significant increase in blood pressure and heart rate. So blood pressure, MAP, SVR, and cardiac output are increased with norepi. In epinephrine, this works on both our alpha-1 and beta receptors. It increases systemic vascular resistance, heart rate, cardiac output, and blood pressure. Some other less common ones that we probably won't see a lot in our practice, but dopamine and dobutamine also work well as vasopressors. And we'll talk about dopamine a little bit because typically dopamine is given with norepi. It's not typically given all by itself, but we'll talk about that when we get to it. The other one I do want to highlight, and you can continue to read the rest of this, but the other one I do want to highlight is vasopressin. So vasopressin acts on the V1 receptors to stimulate smooth muscle contraction. This one also is kind of interesting. It works on the V2 receptors in the kidney, so it acts kind of as like a kidney protectant, which can be really helpful with blood pressure. So vasopressin helps with blood pressure and SVR also, but the bummer with vasopressin is that there's no inotropic or no chronotropic effects with that. So you won't get that contractility piece that you might get with some of the catecholamines. So something to think about, and then you can read about milurone down at the bottom too on your own, but we are going to highlight some of these catecholamines and vasopressors as we move along. So like I briefly touched on the last slide when we were kind of looking at the different medications, and we're going to dive into this again, but this just kind of gives you an idea of the receptor agonists. So your alpha-1s, your beta-1s, your beta-2s, your V1s, your V2s, and then your dopamine receptors. Typically, your alpha-1s are going to work on your vasculature, so it's going to help with vasoconstriction and SVR. When you think about your beta-1s, remember you have one heart versus your beta-2s, you have two lungs. So with your beta-1s, it's primarily going to work on the heart, and you're going to get that contractility piece with it. Your beta-2s are going to be your lungs and your vasculature, so it's going to help with bronchodilation and vasodilation. It's going to affect your SVR. And then your V1 and V2 is going to affect your vasculature and your kidneys, and again help with SVR, vasoconstriction. It's going to be a kidney protectant. So this is just a quick little rundown of just the receptor agonists and how they work, where they work, and we'll touch on this as we look at the specific meds coming up next. All right, we're going to start with the catecholamines. So we're going to touch on epi first. So epinephrine. Epi is an alpha-1, a beta-1, and a beta-2 agonist. So it's going to work on our heart and our lungs and our vasculature. So this is going to cause peripheral vasoconstriction, increased contractility, and bronchodilation, which we often see in our patients, right? Like when we give them a shot of epi, their heart rate's going to increase. They're going to be able to breathe better because of the bronchodilation. And it's going to cause that vasoconstriction, which is going to increase our heart rate, increase our SVR, increase our cardiac output. When do we use this? Typically, we're going to use this in cardiac arrest. We're going to use it in shock. Most of the time, our epi is going to be 5 milligrams in 250 mLs of normal saline or D5W. And our common dosing for this is 0.05 micrograms per kilogram per minute. The maximum of this, though, for epi should be 0.45 micrograms per kilogram per minute. So if you're starting to max out epi, we should be thinking about another vasopressor. When you're looking at titration, the nice thing about epi and norepi is that you can do rapid titration every 2 to 3 minutes because it's got an immediate onset of action and a very short half-life. The bummer is it has a very short half-life. So when you think about titration, you want to go up every 10 to 15 minutes and you want to go 0.01 micrograms per kilogram per minute to achieve your MAP of greater than 65. So not titrating huge amounts here, but you can go up every 10 minutes or so because it's got a quick onset and the effects are almost immediate. Same with norepi, which is why it's kind of nice. With epinephrine, one thing to be mindful of is to watch out for kind of rebound tachyarrhythmias in your patients. So make sure, with any of these things, your patient should be continuously monitored, but watch out for any new tachyarrhythmias with epi. All right, next up is norepi. So norepinephrine, another name for that is Levophed. It used to be kind of the running joke that Levophed leaves them dead, but I feel like we use norepi for pretty much everything these days. It's really great. It's the first line medication for all shock types. But I'm going to give you some tips on norepi so that hopefully, it'll help you as you're using this and titrating this, because we do use it so often. So norepi is an alpha-1, beta-1, and beta-2 agonist. Again, it's going to work on peripheral vasoconstriction, increased contractility, and bronchodilation, very similar to epi. Again, it's our first-line med for all types of shock. And our common dosing, so you have to follow your facility's policy with this on whether we use ideal weight or the patient's actual body weight. I've seen both in my practice. So you kind of need to watch that. It should be on your MAR. And like I said, I've seen both, to be honest. So just make sure that you're following your facility's policy with this. But in terms of common dosing, typically it's going to start at 0.05 micrograms per kilogram per minute. And you will go up to a max dose of 0.45 micrograms per kilogram per minute. Now, I will say, I have worked in a couple of different places, and that max dose has certainly been higher. It's kind of physician preference on how high they want to go up. I've certainly seen it go up to 60 micrograms per kilogram per minute, but again, follow your facility's policy on that. If you're starting to get to the top of this, you might have to consider adding in a different vasopressor. Usually this is in a bag of normal saline or D5W, and usually it's 4 or 8 milligrams per 250 ml. So you just got to kind of watch the dosing. Most of ours are 8 milligrams, but I have seen 4 also. In terms of titration, it's 0.05 micrograms per kilogram per minute every 3 minutes. And you can adjust that to achieve a MAP of 65. This is another one, just like epi. This is great. We can have rapid titration every few minutes due to its immediate action and short half-life. But again, bummer, it has a short half-life. So you might need some continual titration here. Now, a couple of tips with norepi. Norepi can cause brady and tachyarrhythmias, so less likely than epi, but it is possible. So you got to kind of watch for that. It's also important that the body has adequate fluid resuscitation before norepi is administered. So norepi is really good at that contractility piece, but the pump has to be full before it can start to squeeze effectively. And this was kind of the joke when they used to say like Levophed leaves them dead. They were finding that when the pump was not full, the heart can't squeeze effectively if the pump is not full. It needs adequate circulation and adequate fluid in order for it to squeeze well. So this is why we often will give fluid resuscitation in our septic patients ahead of time. We want to make sure that they're adequately fluid resuscitated before we start this norepi. It'll just help that pump squeeze a little bit hard, easier than if it was an empty canister that's trying to squeeze, right? So we want it to be super effective. So make sure you've got your adequate fluid resuscitation on board. One other kind of bummer with norepi, which is interesting because we often use it in sepsis, but acidotic states can diminish the effects of norepi. So like when you think about sepsis or cardiac arrest, so it can make it where it's not as effective in this acidotic state. So you should be using your ABG results to help guide titration. And if you're not getting the desired effects, or you're titrating up and you're not getting the desired effects, you might have to switch to a different vasopressor. All right, so phenylephrine is next. Phenylephrine is a pure alpha-1 agonist. So this is going to work on peripheral vasoconstriction, and it's going to increase your MAP. We typically are going to use this when we have hypotension with tachycardia. It's also kind of a go-to for neurogenic shock. Common dosing is 50 micrograms a minute. So just unlike norepi and epi, that kilogram piece is not in there. So it's 50 micrograms a minute with a max of 200 micrograms total. So This is usually in 20 milligrams in 250 mLs of normal saline or D5W. So you can titrate this dose at 10 micrograms per minute every 3 minutes, and you can repeat your dose. So if you're going to start with 50 micrograms a minute, you can repeat your dose or give a smaller dose every 1 to 2 minutes as needed. However, you don't want to go more than 200 micrograms total. Now, a bummer with phenylephrine is that the duration of action is 15 to 30 minutes. So your titration is going to be slower with this because it's going to take a little bit longer to work. So keep that in mind. Unlike epi or norepi, where you're going to have almost immediate results, this one can take a little bit longer. So you need to be careful. Don't just keep giving repeat doses. Give a repeat dose and wait. And then you've got that max of 200 micrograms total. So you can't go over that. A couple other things with phenylephrine. It can cause reflex bradycardia and tachyphylaxis. So the patient can actually become resistant to the drug over time, causing it to be not as effective. It can also cause reduced cardiac output over time and tissue ischemia, especially if it extravasates. And then you got to be careful with this one in heart failure patients. So, not as common as epi or norepi, but, for a while we were doing phenylephrine sticks, due to saline shortages. So it's not uncommon that we give these little push dose pressors. And, certainly I've seen that at the bedside in my time, a push dose presser. And this is something that I've given as a push dose, same with epi. But I feel like we just don't use it as much. But that might be different in your practice. I'm just talking about mine. All right, so next up is vasopressin. Vasopressin is a V1 and V2 agonist. So this is going to cause peripheral vasoconstriction and help with water reabsorption, which is inadvertently going to affect our blood pressure. Typically with vasopressin, we're going to use this for refractory septic shock. We also use vasopressin for other things, like if we have a diabetes insipidus patient, but the mechanism there, we're using it for a different reason. Typically with vasopressin, we're only going to use this as an adjunct to norepi. It's not typically given alone when we're thinking about vasopressors or vasoactive medications. Like I said, we use vasopressin for other things, but as a standalone vasoactive med, typically we're going to give it with another medication. It's not going to be a standalone. When we think about common dosing, it's going to be different than all the other ones that we've talked about. So this is 0.01 to 0.03 units per minute, right? So usually this is 20 units in 100 mLs of normal saline or D5W. And we're going to titrate by 0.005 units per minute every 10 to 15 minutes until we get to our target blood pressure. So this one is different. It's not micrograms, it's not milligrams, it's units. Vasopressin is a little harder to titrate. So it's not easily titratable due to its long onset of action. So it takes 10 to 15 to 20 minutes for this thing to kind of get into the system and start working. The nice thing is it's got a long duration, 30 to 60 minutes, where our other ones are probably about 5 to 10. So it lasts longer, but it takes longer to get in and start working. So your titration is going to be a little bit more difficult with this one. It's going to take some patience. So if you've got a critical patient who's really hypotensive, this may not be the best medication. Typically, we're not also going to use this with our cardiogenic or hemorrhagic shock patients because it can reduce cardiac output and it will cause more cardiac demand, so it's not a great option. So you really have to be specific on who you use this with. Like I said, most of the time it's given with norepi as an adjunct, but again, it kind of depends on the patient, the MD's preference, comorbidities of the patient, etc. All right, last but not least, we're going to talk about dopamine. So in low doses, dopamine is a DA agonist. In mid-range doses, dopamine is a beta-1 agonist, and in higher doses, dopamine's an alpha-1 agonist. So we talked a little earlier that this has got some kidney protective properties to it. It does increase our chronotropy and inotropy, so it's going to help with contractility. It's going to cause some peripheral vasoconstriction, and it's going to help us increase our MAP. Typically, this one is used for hypotension and shock, and is only used when other vasopressors have failed. We've seen, patients on dopamine and dobutamine, or sometimes they'll use this for a stress test, but it's typically not given all by itself. Typically, we're trying other things, or when these, it doesn't work in other situations, or we're maxed out on our pressors, those kinds of things. This one has some risks with it, aside with everything else, but I'll talk about those in just a second. Dosing on this one is interesting. So dopamine, it's common that we get it 400 milligrams in 250 mLs of normal saline or D5W. Your common dosing for this is 2.5 to 20 micrograms per kilogram per minute, whereas everything else is so minuscule. This one's kind of a bigger dose, and you got to titrate this one too. When you titrate, you want to titrate 2.5 micrograms per kilogram per minute every 10 to 15 minutes to get your MAP above 65. This one, just like vasopressin, is not easily titratable because, again, of its long onset and its long duration. Again, this one is typically used when other vasopressors have failed. It can cause some hypotension, rebound tachyarrhythmias, pulmonary congestion, and if it extravasates, you can get major peripheral necrosis and gangrene. So you have to be really, really careful that you are infusing this into a big vessel. And we're going to talk about what type of monitoring and stuff we should be using for these. But if you're going to run a vasopressor of dopamine, if you're going to use dopamine as your vasoactive agent, it really should be through a central line to help kind of minimize that peripheral necrosis. And then just like norepi, this one does not work great in acidotic environments. So if you've got a septic patient, this may not be the best because it just is not as effective as others. All right, so all patients that are getting a vasoactive medication require close and continuous monitoring of their vital signs, fluid status, and labs. As we talked about already, the goal of titration is to maintain a MAP of 65 or greater. Central lines, arterial and venous, should be considered if the patient is going to be on a vasopressor longer than 2 hours. So in our facility, norepinephrine is okay to run through a peripheral IV for 2 hours or less. So if the patient's going to be on it for longer than 2 hours, we really need to consider a central line. And we talked about this a little bit, right? If these things extravasate, we can have some really bad tissue necrosis. The other thing is we talked a little bit about, titration. When we are thinking about putting these patients on a vasopressor, we're doing this because their blood pressure usually sucks. And we want to put in an arterial line so we can get the most real-time evaluation of blood pressure, which can help with accurate titration. Certainly, you can use an external blood pressure cuff. You can do that, but if we're really going to be titrating these medications and we're using just such small amounts every titration, it is vital that we use an arterial line to give us those really accurate blood pressure readings. And to be honest, if our patient's on a vasopressor, they're probably critical and we should be considering a central line for them anyways. With an arterial line, we do not infuse anything through the arterial line. So if we're going to do a vasopressor, the arterial line would give us real-time evaluation of blood pressure, and it'll help us with ABG blood draws. But to run that vasopressor, we would need to put in a venous line as well. And often, they're put in at the same time, an art line and a venous line. But getting those central lines in place are really important. When we have a patient on a vasopressor, it's always important that we keep reevaluating the patient's cardiac neurorespiratory status. And then we should also be assessing for pain at the insertion site, skin assessments, signs of extravasation, infection, etc. When we've got a patient that's on a vasopressor, things to consider in terms of labs would be a CBC, a CMP, your ABG or VBGs, your cultures, whether that's urine or blood or sputum or whatever, a lactate, your liver and kidney function, urine studies, etc. All right, so let's use what we learned about vasopressors and let's do a little case study. All right, so this is Miss Sharon Jones. She's a normally healthy and ambulatory 84-year-old female. Recently has become lethargic, less active, and anorexic over the past week. She complains of diffuse lower abdominal pain unrelated to food or bowel movements. Here's the kicker. Miss Sharon was diagnosed with a UTI by her primary care physician 5 days ago and was started on Bactrim for 7 days. Sweet little Sharon, she got so nauseated that she stopped taking her pills after 2 days and never finished her antibiotics. So follow along on your worksheet and we'll let this case study unfold. So in triage, Miss Sharon, her vital signs are as follows. Heart rate of 110, respiratory rate of 28, blood pressure is 90/42, so that gives you a map of 58. You're welcome, I calculated it for you. Your temp is 101.5 Fahrenheit, your oxygen is 94% on room air, and Miss Sharon weighs 115 pounds, which is 52.2 kilograms. She is shaking and complaining of chills. She complains of this ongoing fatigue and diffuse lower abdominal pain. Past medical history, she's got type 2 diabetes and hypertension. She is allergic to amoxicillin, and she takes lisinopril and then metformin for her diabetes. So, based on the patient presentation, are you concerned about anything? Fill that in on your worksheet. What assessments will you complete? And then think about our standing orders and what standing orders would you put into place at this time if you were the triage nurse? So the case study continues. These are your assessment findings. So she's tachycardic. Her EKG shows sinus tach. She's anxious, restless, confused, and disoriented. She has dyspnea on exertion, shallow breathing, but her lungs are clear bilaterally. GIGU, she's got this diffuse lower abdominal pain, nausea, and anorexia. She's got increased frequency of urination and foul smelling urine. Her skin is flushed, warm, and dry. However, she complains of chills. And she just complains of generalized fatigue, lethargy, and malaise. You can pause here. Here are a copy of her labs. So you've got your CBC, your lactate, your VBG results, your CRP, your blood culture, your basic metabolic panel, and then your urinalysis as well. So take a peek at those and just kind of make note if anything is abnormal. The doc sees these labs and he tells you to initiate some fluid resuscitation, so 30 mLs per kilogram. Maybe we'll have to do a little more, we'll see. We're going to measure that serum lactate, and if it's greater than 2, we're going to repeat it after fluid resuscitation, so in about 1 to 2 hours. If the patient's blood pressure is unresponsive to fluid resuscitation, we're going to start a vasopressor, and we want to maintain that map of greater than 65. If we're going to start a vasopressor, we're going to use an arterial line to measure accurate blood pressure and titration of that vasopressor. And then we're going to administer broad spectrum antibiotics after 2 sets of blood cultures are obtained, and he is recommending Zosyn and vancomycin. As you're getting the patient a little bit more settled and getting some more charting and history done, the tech takes a new set of vital signs and reports the following. So blood pressure is 84/40, map of 54, pulse is 118, respirations are 28, temperature is 102.5, oxygen is 92% on room air. Are you concerned by any of these and why? Make sure to put that on your worksheet. And then, does your patient meet any SIRS criteria? Why or why not? So you may have to look up what the SIRS criteria are. But looking at vital signs and labs, does the patient meet SIRS criteria? Why or why not? Put it on your worksheet. So as the case progresses, we're thinking that we're going to transfer this patient to a higher level of care. Unfortunately, Regions won't have an ICU bed available for 4 hours, so the patient is going to board with you. The patient has received 1,600 mLs of normal saline per that 30 ml per kilogram protocol. However, she remains hypotensive and altered. So based on your doctor's orders, what are you going to initiate next? Make sure to mark it on your worksheet. If you chose start a vasopressor, you are right. So based on the medications that we talked about, which one are you going to choose and why? There may or may not be a good answer here. I mean, there are a couple good answers, but I want to know what you think. Based on the one that you choose, what is going to be your starting infusion rate? How are you going to titrate the medication dose-wise? How often are you going to titrate the medication? What is your blood pressure or MAP goal? And then lastly, are there any other patient assessments to monitor or gauge the vasopressor effectiveness? So how do you know that the vasopressor is working? What other assessments of your patient are going to clue you in that this vasopressor is working? So fill all these things in on your worksheet as well. So lastly, before the patient transfers to Regions, the patient's daughter and husband ask you why this all happened. They want to know if there was anything that they could have done differently. So on your worksheet, what reasons would you provide? What patient teaching is important to share with the patient and her family about sepsis? So think about that, put it on your worksheet. So thanks for following along. These are the references. There is a ton of information on vasopressors. I wanted to just do like a very basic covering of this. You could certainly dive into the pathophysiology of this and all the way down to the cellular biology of these things. But again, I wanted to just kind of get a basic overview and talk about some of the common ones that we see in our practice, and just do a little refresher on dosing and titration. And if you have any questions, let me know.